treatment of patients during their lifetime and the lifespan. The prevention, by preventing the placement of the initial restoration or the first surgical, periodontal, or plastic surgical procedure through improved and informed oral hygiene methods and routine care designed for the individual specific needs of the patient. Meaning, many times we may have to see a patient every 3 months or every month based upon the specific needs of the patient. And preservation through conserving hard and soft tissues. During the operative procedure, minimal invasive procedures with adhesive dentistry or with surgical procedures. We can use these periodontal plastic surgical procedures that you'll see in several of our books that preserve, conserve, and modify the anatomical form and contour of the hard and soft tissue, such as socket preservation, when you want to preserve the facial plate and the papillae prior to placement of an implant or doing a prosthetic bridge. Or anterior ridge augmentation to restore vertical and horizontal deficiencies. Or when we want to use connective tissue grafting with conventional methods to improve the harmony of the periostetic harmony with a lack of attached gingival tissue. Or when we want to preserve through tunneling techniques, which are more minimally invasive, and then we optimize the vascularity by eliminating the need for vertical releasing incisions. So the third P, perpetuation of longevity, increasing the interval of time between restorations and surgical procedures. And so we can have this perpetuation of longevity if we utilize optimal adhesive protocols with these highly filled flowables and with conventional hybrids. And we can also have longevity with directly placed hybrid composite materials. As you can see here with a 17-year-old post-operative procedure. We'll share in a moment. And you can have longevity with injectable materials, as you can see with this 6-year post-operative procedure on a patient. And you can see that the longevity with ceramic restorations, and you know that for longevity of tooth and for restorations, the patient has to be part of the solution. Now, in the past, and many of you may not remember this, but the restorative concept was form and function. And with the metallic restorations, the principles of extension and prevention and resistance and retention form were so significant. But in 2020, our patients want tooth color restorations, and the restorative equations changed. It's aesthetics. And many clinicians continue to use yesterday's procedures and today's restorative biomaterials, and they wonder why they have micro leakage and recurrent decay and sensitivity. But in 2020, our patients want an adhesive design concept. When considering the biomaterial selections, and when there's so many different ones, and patients need to be informed, and when we're discussing those today, require the utilization of adhesive preparation designs that are more minimally invasive and require a more thorough adhesive technique. And of course, we need an adhesive design concept when we select our technician, because different technicians utilize biomaterials differently, as you know. And of course, we need it when we consider preparation designs, because with adhesive preparation designs, they can be more minimal invasive. My teacher, Willie Geller, says that still today, he thinks that many preparations they call minimal invasive are still too invasive. And placement procedures and techniques. We have to be concerned with the restorative interface because it's constantly subjected to internal and external stresses. And then we have to think about that three-dimensionality when we're bonding. Even a veneer, we have to think about the interface and the stresses. And of course, research, and Richard Price, we have to mention his name. He's our genius when we talk about curing methods. But the orientation, the design of the curing tip has significant impact on the amount of energy delivered to the restoration. And it can affect the physical properties of the resin and the bond strength to the tooth. And I think to have an adhesive design concept, we also have to think about patient selection and compliance, because the patient has to be part of the solution if we want longevity with adhesive restorations. And that means they have to be informed, and they make better choices when they're informed. Now, When I talk about thorough restorations and adhesive restorations and being precise and detailed, it reminds me of last week, this two little girls, and while they were having their teeth cleaned, one of them gave me this little drawing, and it's a comic. Her name was Gracie, and she's on the left. She's 9 years old, and I said, "This is beautiful," and she replied, "Everything's in the detail." And this is what I need you to think about always. Now, Melissa and I will go around saying, every time we do something, everything is in the detail. So now, to further understand the adhesive design concept, just for a moment, I'd like to take you on from past to present, a timeline of aesthetic challenges of adhesive restorations. So what has been and where are we going? And with aesthetic challenges that we're faced with, it all begins and ends at the interface. And we think about the restorative material is bonded properly in what we get. Reduction in micro leakage, reduced staining, recurrence of caries, improves retention, reinforces the restoration, and dissipates the forces across the entire interface while improving aesthetics and wear resistance. But as we talk about the 90s, I'm going to take you through on some cases that we did and why, and we look at these. In the past, we had to compromise because we had to use a hybrid and a microfill because of the inequities of the materials. So at the time, we were utilizing these, and you can see that we had to layer the material. But from that, we got the durability of the polish from the microfill and the incisal edge strength from the hybrid. And when we put them together and mix them, we gained something else, polychromatism, the polychromatic effect. And so we got something from that, and we learned a lot. And so when we were utilizing the microhybrids in the turn of the century in 2000, we were utilizing them in posterior for incisal edge strength and also for structure strength and durability of the polish. And of course, we were utilizing flowables for internal adaptation of the adhesive system and to provide an elastic layer so to absorb the flexural deformation of the tooth. And so there are many techniques that we could use with incremental layering techniques, such as oblique layering, and there were others, such as horizontal and vertical, to manage this polymerization shrinkage stress. But when we talk about the fact that we multi-layer, it wasn't just for aesthetics. It was also to reduce the polymerization shrinkage and also for densification, marginal adaptation, controlling overhangs in the lateral margins, reducing the effects of shrinkage stress, and also to allow us to use the curing beam according to the position of the material. And the most important was, if we had the anatomical contours correct by developing it from the inside out, we'd have less finishing. So less wear on the restoration and less dissipation of heat. And so we can control the light intensity and thus the plasticity of the restoration and the stability of the interface. And it's like Richard Price always says, Dr. Richard Price says, from Canada, it's how long are we curing? What's the size of the tip, the intensity of the tip, the shape? All these things we have to think about. And in our book, Flowables, and also in our Aesthetic Restorative Third Edition, Dr. Price discusses all this in detail. And if you haven't read it, you should. In the 2005, the mid-decade with the nanotechnology, molecular engineering, we also saw that the filler particle sizes the interparticle spacing was smaller, and we had better handling properties and physical properties of these materials, these conventional hybrid materials. And of course, we were utilizing them in the clinical indication for anterior and posterior restorations. And of course, we see that with the nanoparticles in 2011 and 13, such as Clearfield Majesty and Tetric Ceram and Genia Universal Flow, these flowable injectables, we call them injectables now instead of flowables, they were highly filled and they had closer interparticle spacing and improved silicization technology. And so it improved physical, mechanical, and optical properties. And so you can see that we're utilizing them in the anterior and posterior restorations, and we have been getting very good results for long term with good maintenance. As you can see, specific flowables are the ones that we need to talk about, though, and we'll be talking about today, because there's certain ones that Dr. Powers and Dr. Burgess and I think we should be using because they are new and improved. And they have shown that similar clinical performances to their hybrid counterparts in research. Notice the biomaterials improve the mechanical and the physical and optical properties, and the preparation designs become less invasive, and the aesthetics is simplified. And I think as you see these newer formulations of supra nano hybrids, they have this additive color mixing, which is coefficient absorption that takes the color of the tooth. So really now we don't have to think about the significance of layering. It's for managing stress, but not for color. Now, as we've moved along the timeline from the past to the present, the challenges remain the same. To be able to utilize the material of the time with the proper technique to create aesthetic and restorative excellence. That was the aesthetic challenge. And it's not so much which material we use, but how we use the materials of time with the proper techniques and concepts to create aesthetic and restorative excellence while also improving longevity of the restorations. And so when I talk to you about, and you see me lecture on presentations where Olivier Trick shows a ceramic restoration that has a cutback technique with metal, and it looks better than the all ceramic restoration because he knows the technique and he has it down. And so it's the material and the technique together. So, and 12 years ago, Dr. Burgess and I were talking about flowables, and he indicated in his research that, hey, I don't think this is a really good idea for posterior restorations, but then he tells me, hey, I'm getting some long-term clinical results, and they show promise. And I said, well, I'm doing the same with injectables. And so, as you can see, we have long-term results. Now I have 13-year follow-ups, but you can see the 7-year posterior follow-ups on the posterior restorations here, and 5-year follow-ups and 2-year follow-ups. Now, indicating from his studies, indicating that this supported our clinical findings, that the wear of the restorations for certain specific ones, like Supreme Ultra, which is the longest running flowable that we used, and Genio Universal Flow and Herculite Flow and Grand Neo Flow, some of these had less wear than their other flowables. So we need to be specific, and in my book we talk about the ones that are significant for you to use at the moment. And other companies are changing as we talk. But the question is, which is the flowable and which is the hybrid? Studies by Karaman, Semino, and Salerno indicate wear and mechanical properties of the flowable resin composite tested similar or even improved performance compared to the counterparts in conventional hybrids with posterior lesions and with non-cervical lesions. And so when we look at three-body testings by GCR&D, you can notice that specific flowables such as Filtex Supreme and Genio Universal Injectable and Genio Universal Flow, you can see that they had less wear. And of course, the data reported by GCR&D indicates that Clearfield Majesty ES Flow Low and Genio Universal Flow and Genio Universal Injectable had mechanical properties similar or better than their conventional hybrid counterparts. And so what I want to say is this: in the 90s, they were a mistake. But in the 2020, these materials are revolutionary. And so also, I would like for you to look at some of the past and current supporting research. And in my books, we have, very much scientific data to sharing with you all this information. Now I'd like to share with you my technique with a little imagination. Developing a functional prototype is how it began. This composite mock-up with flowable composites is an excellent tool for increasing the patient's understanding and education of the clinical procedure through a visual prototype. They can test drive it while we as clinicians and our interdisciplinary team, we determine the function, shape, contour. We can even use them long-term, so we can do connective tissue graftings or crown lengthenings or ridge augmentations, and we can have these restorations and they're bonded to the tooth. Now, interesting, it just requires a clear vinyl polysiloxane impression. I helped develop with GC one called Exiclear, but there's also Memacil 2 that we used initially, and it can be used to replicate the diagnostic wax up. It also transfers the material to the tooth that's to be restored as a transferring vehicle, and also to be injected through, which we'll share in just a moment. So the prototype is an integral component to development of management of soft tissue profiles and the design and function for the definitive prosthetic rehabilitation that we may want to go to. And so I'm not telling you that these restorations are all you should do, but I have found by leading these cases out that I have long-term results with good maintenance. This 40-year-old patient, he presented with no aesthetic concerns at all. He just had incisal wear and chipping on his anterior teeth. There was no posterior disclusion and no guidance. And so we began with occlusal therapy and an appliance, and then afterwards we made a new occlusal scheme with a diagnostic wax up, and then we had guidance. We had protrusive and we had posterior disclusion, and as you can see, and then we made a guide. And this guide was made with Memacil 2 over the wax up, and then we make a little opening over each tooth to be restored. I use a 6847 by Brasseler. It doesn't, it seems to work best, but you can also use an ET6 fluted burr. And then we get the shade. And we utilize these 2-layer shade tabs by R.S. Kulzer, and I used a mixture of A1 and B1 on this case. One tooth at a time. Each tooth's pumice, then we acid etch it, we place adhesive, we air dry it, we light cure it, and then we remove the excess in the interproximal region with a barred Parker, and then we're ready to rock and roll. And then we place our Teflon tape, we place our guide over the tooth to be prepared, and then we inject our mixture. Now we do the A1 and the B1 together, A1, then B1 in the middle, and then we light cure. Now, if we're changing proximal surfaces or incisal edges, we'd want to use an opacious first. But we mix the colors just like we did when we were utilizing hybrids and microfills. And then we stabilize 40 seconds from the facial, occlusal, or incisal, and the lingual aspect. Now, the scoring technique is done with a barred Parker, and if there's any periodontal residents taking the program, the ones that I've taught in the past, you don't want to use a double blade, but you want to use a single blade 12. And so you want to go very closely to the tooth and score it like you do glass twice, and then it just clips right off. You don't have any fracture lines at all. I never have had. I use the Zirca. As you can see, the Zirca here. The Zirca, let's go back. You see the Zirca, or an 8A at the margin, and then we finish with finishing disc. And then I love this 274 that you can see right here by Brasseler. And that's all I use on linguals and on occlusal surfaces of molars. And then finishing strips to reduce the potential for sequelae, periodontal sequelae by resin tags in the interface, and then silicone points and cups. And then, as I've noted for with the piano, of course, maybe you remember, but the goat-haired wheel using staccato motion, bump, 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 and a very light motion with a silicone, with a diamond paste. I like the one that Oliver Trick has, and then a cloth wheel dry with a staccato motion. And as you can see, the completed polished composite restorations, and you can see that this nano hybrid flowable, this was Genia Universal Flow, but you can see that the patient has nice excursions and protrusive, and we have form and we have function with a little imagination for the personality of our patient. But more importantly, if you look closer, you can see a 6-year follow-up. Now, as we look closer, you might see a little, you see the function, still have great function, but as we look, we have a little bit of wear on the lateral left side and cuspid, and on the right cuspid. And so just with a little bit of time, 5 or 10 minutes, we can place a cord, we can roughen the surface, we can We can acid etch the surface, we can silinate it, and then we can air dry it. We can place our adhesive, and we can rock and roll with a little flowable, and they're good for another 50,000 miles. Now a video to show this concept. The clear silicone matrix is precisely placed over the maxillary arch and inspected for a complete seat and seal. An A1 shaded flowable genial universal flow is applied with a syringe tip. Notice the controlled fluidity that comes from the syringe tip design and the thixotrophic property of the material. Thixotrophy is a structural breakdown of a material so it flows through the syringe tip when the material is stressed, and then the hydrogen bonding restructures and it becomes more viscous. Also, by maintaining a constant finger pressure on the buccal and lingual ends of the matrix, an optimal adaptation of the material to the tooth surface can be accomplished while reducing the potential for voids and ensuring precise contour and form. The excess is expressed with this pressure and the residual material is removed using an M1 ball-tipped instrument by American Eagle, and light cured from the incisal and facial aspect for 40 seconds. Bruno and Asmussen suggest using a slower polymerization, which causes an improved flow of molecules in the material, decreasing the polymerization shrinkage stress in a restoration. The silicone matrix is removed and the excess polymerized composite resin was removed from the scalpel blade, a number 12 beading bar Parker. The proximal surfaces are inspected for adequate contact and any residual resin tags or overhangs. The effectiveness of the finishing and polishing can be reflected by the type of composite resin utilized. Now this video is in the book with a QR reader with 5 others. Now maybe you remember this patient, but 24 years ago he wanted to change in color and notice the Warren restorations and composite restorations. But at that time, 24 years ago, I made an acrylic matrix and a diagnostic wax up, and like I said, I had to combine the two, hybrid and microfill, to restore this and take the inequities of each product so that I could improve on that. So that's what we did. And so as you can see, the direct bonding procedures, I did 10 veneers, and I placed my hybrid with XRV Herculite, and then I smoothed it and got my length with the guide at that time, and then I layered by internal characterization, and I used my guide, my shade color mapping guide, and I placed a hint of blue diluted and a little ochre at the cervical region here, and then a little white in this region, and I would place the gray, but each one individually in light curing for 40 seconds and stabilizing. Now, interesting, we're going to think about color variation creates what? 3-dimensionality. So by this color variation, we create 3-dimensionality. And as you can see, you have some depth with these nuances in the incisal third and the white on the proximal surface, as you can see. And so then we overlay with an artificial enamel layer. This light goes through it, it's translucent, and then we finished and polished. But interesting is, as you look, that this takes longer with the direct bonding. These 10 restorations took about 6 hours. We finished and polished, as you can see, utilizing goat-haired wheel and cloth wheel staccato motion. And here's the final restorations. As you can see, a nice integration between the composite, the tooth structure, and the soft tissue. The patient wanted to change in color, but we used the color of the substrate to create natural aesthetics. We changed the incisal silhouette so it follows the contours of the lower lip, so you can see very natural aesthetics for the personality of our patient, Stefan. But more importantly, because he became part of the solution, you can see that 12-year postoperatively, it's still looking quite nice. And here is a 17-year postoperative result. But more importantly to the story, I want to take you on a new direction. Stefan came to me 24 years later, and he brought me this Malbec. It's a very nice South American wine. He said it's not expensive, but if you let it breathe for about 30 or 40 minutes, it's very nice. The name of it was New Direction. And I said, this is amazing. So I bought a lot of it from my cellar, and I let it breathe. But here he came back, and you know that many times when we drink wine, there's some studies by Omata and colleagues indicating that color changes in resin occur from intrinsic and extrinsic factors. 3 of those that were studied were coffee, tea, and wine. An alcohol component in wine roughened the surface, thus increasing the potential for staining. However, coffee and tea in conjunction with chlorhexidine use also had similar results. So we need to think about these things. So what I did is I took the original diagnostic wax up that I had in storage, and I made a matrix with Exiclear. This is the one that I helped develop with GC. And so then I made my opening with a 6847, you see. And then this is by Brassler. And then I made my preparation, an intra-composite preparation. And then after I did that, I started on the premolar so he could see it first. And then I acid etched, and I placed silane and adhesive and air dried. And then I placed it back over the matrix over the area, secured it with my thumb and index finger, and I injected. And the mixture was an A1B1 mixture. And they were both translucent. And then I light cured. And then I finished the edges. And then also I take a DET3 diamond by Brassler, and I retract it with an 8A instrument and finish the margin. And then I take a Featherlight, and this is my favorite wheel, a Featherlight, and they make it for composite and ceramics, and I polish the surface, the facial surface. And I did this restorative sequence for each tooth. This was the cuspid, and I did the same procedure, injecting with the inverse injection layering technique, stabilizing with the curing light, close proximity, removing the excess resin with the scoring procedure. And when you go around this area, it's very important that you don't cut the tissue. And then you can ask many of my residents. And then you then you cut the sprue, and then we finish the lingual surface. Now notice the lingual surface. It's so smooth already. It's very nice, just like a veneer, a ceramic veneer. And polishing the lingual surface also, and you can also use this on the incisal edge as Featherlight. And then cups, and I like this cup to go up in the sulcus, and sometimes I'll take this cup, this is by Brassler, and I'll take it on a stone, so I thin it a little bit, and as you can see, it's a little bit inflamed right there. And then the diamond, and then a goat-eared wheel with diamond paste, and then I rinse it, dry it, and use a cotton buff. And there's a kit that they have for this that I make. And then as you can see, notice the optical integration at the interface and the improved luster and color. And the patient wanted me to do all 10, and so we did. And so 24 years later, he's resurfaced. And he's good for another 50,000 miles. Adhesive dentistry is exciting. Okay, so I want to say the journey of discovery is not based on going to new places, but seeing things with new eyes and using your imagination. And it's so important that you use your imagination. Now, this is a friend of mine. Her name's Lucy, and she lives down the street from my office, and she was quite grumpy and needed an equilibration. So we do this procedure called floating. In fact, my dog needs a root canal. Can you believe this? And I'm going to the vet in a few weeks to help with the root canal. But we do this floating procedure, and it flattens off the planes where they've erupted. And she kicked me several times during the procedure. But now her function has improved, and we definitely want women that are happy. And she's a happy camper now, and she and I go riding on Friday afternoons when I'm in town, which has been quite often lately. Now, just for a moment, I'd like to share with you the orthodontic space management with this injectable technique. Now, many of you thought maybe I'd give the same presentation, but I don't like to do that, and I like to think about new things to show you, and all these things are in the book. But let's just talk about space management for a second, because many of you probably have patients that have gone to the orthodontist and they needed an implant or they needed peg laterals, and then they came back and they didn't have enough space or had too much from the orthodontist. So this is a great communication tool. This patient was 11 years old when she came to me, had 2 size discrepancy on the maxillary anterior segment. And as you can see, there were proximal caries on the distal and mesial of the teeth, and we had some radiographic findings. And during orthodontic and restorative evaluation, the patient and parent were educated on the significance of achieving this space and knowing where the orthodontist knowing where we're going before we get there. And so he needed to know the anticipated result, and his might not be the same as mine, so I want to direct him, and this is a great way to do it. And so we get the radiographs, and you can see the caries, and so we begin with a diagnostic wax up, and these are the shapes, and this was done by Bruguera, August Bruguera in Spain. And so this is where we want to go, and so we make our matrix, and this was Memicil too. We place our opening above the teeth to be restored. We use the 2-layer shade tab by Horace Kulzer to mix the colors. We wanted I think this was an A1, B1, and it's an opacious A1 and a B1. And then we inject them. The opacious blocks the light in this region, and then the translucent goes over it. Now, when you learn to mix colors, and I need to write something on this, mixing colors is so much fun. And when you're doing multiple restorations, it's so easy because you can remember what you did on the left cuspid, and you can remember it when you do the right one. And you can make them similar. Or if you want the cuspids to be a little bit more chromatic, then you might want to use an A2. So this is how it works. And so then, as you see, we have the sprue. We remove the composite sprues, and you can see they're ready to rock and roll and go to the orthodontist. And so here she is at 11 years old with an optimal anatomical form for the laterals, with a nice biological framework for these transitional restorations. And so we were able to manage this 2-size discrepancy with this pre-orthodontic treatment planning stage and this simplified technique. And very minimal preparation, just removing the caries. And of course, you can see 7 years follow-up when she's 18 years old, nice function, and minimal wear. And so I say from 11 years old to 18, in the power of a beautiful smile. Now this next patient is a very wealthy patient, and he's 63 years young, and he had some incisal wear and fractures. But he wanted a conservative aesthetic enhancement. But notice he doesn't smile. If I go back, he repose and full smile, that's full smile. So he's not so excited about his smile. And so we viewed the case, and he had multiple diastemas. In fact, the one between the centrals you could drive a truck through. And so you can see the multiple diastemas. Now, in my book, I compare this to the older technique, conventional layering technique, and show how much easier it is and more predictable. Now, if you'll notice, he also has cervical biocorrosion. We don't call it erosion. I saw this in a lecture the other day, erosion. Land erodes, teeth biocorrode. And so you can see the central incisors, and he said that this happened when he was younger and he used to like to suck lemons. But he doesn't do it anymore. So we have our preoperative model, and then we make our diagnostic model, and this was done by Victor Castro, very talented technician, and also Bassam Haddad, which is an oral design member, and then I made modifications to the wax up. And this gives us the functional aesthetics that we need. Then I take the guide that I made, non-perforated, and I place my Exiclear. This saves material this way because it's custom made. And then I drill my holes, orifices above the teeth to be restored. Another video for the matrix. method to eliminate voids with pressure. A diagnostic wax-up was used to establish new aesthetic and functional parameters for the definitive restorations, including function, tooth position and alignment, restoration shape, physiological contour and texture, incisal edge position, and gingival orientation. The diagnostic wax-up was submerged in bottling soap for 15 to 30 minutes to seal the pores. This thin consistency does not affect the occlusal and translation accuracy. However, it improves the clarity of the impression material. A clear polyvinyl siloxane material, Exiclear by GC, was injected into a non-perforated tray. This can also be formed on a stone model that is a duplicate of a wax-up, or in some cases from a pre-existing diagnostic model where there is no requirement for change in the anatomical form of the natural dentition. It is important to keep the tip of the syringe submerged in the material to reduce the formation of voids. The material is injected onto the diagnostic wax-up model to replicate the diagnostic wax-up. Immediately position the tray and the material over the diagnostic wax-up model and use a firm and even pressure to seat until the gingival contours of the diagnostic wax-up are completely encompassed by the material. The model and matrix are placed into a compressed air chamber to eliminate air voids from the material. The lid is secured and the air hose is connected to generate pressure. The material is pressurized until initial set is complete. After 3 minutes, the lid is removed after the pressure is completely relieved. Notice the clarity of the material and the lack of air voids. A small opening was made above each tooth that was to be restored using a tapered diamond burr, a 6847 microaspirate. It is important to clean the internal surfaces with a microbrush to prevent silicone debris incorporating into the flowable material. The completed clear polyvinyl siloxane matrix. This clear matrix can be placed intraorally over the prepared or unprepared teeth and used as a transfer vehicle for the flowable resin deposit to be injected and cured. This clear vinyl polysiloxane material, Exiclear by GC, allows you to visualize the injection process with a flowable material such as genial universal flow. And you can eliminate any voids by compressing the matrix from the facial or buccal and lingual. And also, you can see the orientation of colors of the flowable before light curing. Now, we'll proceed. So the first thing I did was I take a little hybrid and I just made a mock-up and put it in the matrix. I didn't bond it. I just wanted to reduce the amount of injectable material and control the large diastema since it was so large. So I just light cured it, no bonding. And then I take my Teflon tape and I place it in an acid etch, adhesive, and air dry and light cure. And then the next thing I do is I take my mixture. Now I wanted to use an opacious A2 because I want to make sure that I'm blocking the light in the diastema. So I take an opacious A2 and then I use a B1 translucent in the center of the tooth. And then as you can see, I inject it, I hold the ends, and then I light cure, and then I do the scoring technique with a Bart Parker, and then finishing off the sprue. And then it's very important that you take an 8A or a Zirca, an 8A by Ufridi, and you hold the tissue back and just finish the margin so there's no overhang or in the restoration in the sulcus. Very important. And you take my course as we show you these things. The initial hybrid mock-up, as you can see, on the maxillary center was removed, as you can see here. And then we finish the margins, and then we do finishing strips with aluminum oxides. And we finish each tooth before we go to the next. Now, I've had prosthodontists ask me, why can't we just do them all and then finish? Because then you'll have a mess and you can get off on center, and then you may not have exactly the right position. Now, there are some other people trying different techniques, and they alter the teeth, and they'll inject one, and then they'll do the cuspid and come back and do the lateral, whichever you prefer. Then, as you can see, the same procedure is done on the right central. And then removal, and then finishing with a disc and H274, as you can see here. and then points and cups, and then goat-haired wheel with diamond paste, rinsing it off, drying it very well with a cotton gauze, and then using staccato motion to create the high surface reflectivity. And you can see the completed transitional restorations. And we have form, and we have function, and we have aesthetics. And the patient wanted a natural smile. And now he has a full smile. And interesting is, we can do more if we want. We can cut back and place color. But you know what's interesting is, he helped me when I did this exposure of Medicaid fraud for $4.3 billion in Texas. And he was very instrumental in taking me to the Capitol. And he used to tell people, I just got liquid enamel now. And he was in his big swimming pool, and he was swimming, and he came out of the water all wet, and he was just smiling with his teeth. Adhesive dentistry is exciting. You can see a 1-year follow-up, and you can see an 18-month follow-up, and a 2-year follow-up. Now, you may remember the last time I was at UPenn that my baby's name was named after James Rodriguez, my favorite soccer player. Well, we call him Sir James now, and he plays soccer just as good as my favorite soccer player. And so, but since I showed you him last time, he's been a little busy. He got a new girlfriend, and he has 4 new babies, and so I guess that makes me grandfather. Developing a posting core. Now, with my new book, it's going to be called on posting cores. It will be coming out in January. And I think it's going to be really good for telling you how to save the tooth. And if you can't, and if it's an end-stage tooth, then we have implants in the book too. And Marcus Blotz and Dr. Powers and Dr. Richard Price and Dr. Burgess are all involved. Maybe you've seen this thought that's coming out, but I want to share with you this cool technique. The restorative failure was an all-ceramic crown that fractured, and this is what was left. And we have enough that we have a ferrule effect that you see here after curetting. So we were going to use, a patient was explained to that we could use a fiber-reinforced posting core system. So the way we do it is we make a diagnostic wax up precise, and then we make our exit clear matrix, and we take it off and we drill a hole. And then we place it in the, we'll place it in for no voids in the pressure plot for 5 minutes. So we don't get any voids. Now, if you don't get voids on the internal surface. I don't know why, but you will see them inside the material. I don't like that. A small hole was made above the tooth the tooth to be restored, and then you want to make sure that you clean it well with a microbrush and rinse it out and make sure there's no silicone debris that can contaminate the flowable material. And then we determine the post channel length, and it's 1/2 to 2/3 the length of the canal. We place our dental dam utilizing a modified dam technique, and you can put a little super glue here, just a little bit, not much, infinitesimal amount to stabilize. And the gutta percha was removed, and we utilized Gates Gliddens, and then of course the color-coded rebuilded drill post from Boco on this system. And interesting is that microleakage is reduced considerably when we leave an excess of 4 millimeters of gutta percha, according to Zimmer and colleagues, at the apex of the canal. But we also want to make sure that we have coronal seal through making sure we have a good monoblock system and we have no micro leakage. And in my book, I spent a lot of time during this coronavirus researching and writing this book, and it's taken about a year, and I hope you enjoy it. The prepared channel was rinsed. We take a paper point and move it around and get the excess, and then we make the selected post. This was a Voco rebuild post, and then from that, then we'll take, I used chlorhexidine, wiping off the remaining residual, absorbing it with a paper point, as you can see here. And then we use a TIM. I like these from Voco. They're long micro brushes, and we work the surfaces of the sides of the tooth, and then we absorb the excess adhesive and then light cure. And then a dual curing resin, we use B-Fix QM, was injected into the post with an angled tip, and we pull out slowly, not to have any voids, because these can affect the interface and from debonding. And the fiber post is immediately inserted, as you can see. And you see we have the marked spot of the anticipated height of the abutment. After polymerization, we cut it with a diamond to that height. We acid etch the periphery, and then also we silinate and place adhesive on the tooth and the post. And then we place our matrix, and I injected an opacious, this was an A2 shaded flowable Genio universal flow, and we lacquered and stabilized, removing excess and finishing the margins, and it's so beautiful. Optimal integration between the components of the system gives us structural integrity for intraradicular rehabilitation. And so this is a simple procedure, and if you had multiple posts, you can do this very quickly and very efficiently and precisely, and there's no adjustments. You can go in rock and roll and take your impression. You know I'm from Texas, and this is the only time I don't use a dental dam, is with a heifer in the field. But I do try to use my magnification. Now, not closing yet, but I have a patient that I want to share with you with two different techniques and materials using this injection technique with a cutback technique. And so let's do that. The young lady presented with a fractured maxillary central, and she had other caries in her mouth. And so I told her I would do this case free if she would learn to take care of her mouth. And so we did a diagnostic wax up and got the contour that we wanted, the shape. And then we made the PBS matrix, exit clear. And then we made an intracoronal, about a 0.3 millimeter veneer preparation. And then we acid etched it, total etch technique, adhesive and air dried, and light cured. And then we placed the matrix over the anterior segment, and we injected. I used an opacious and an A1. And GC is, I think, the only company now at the moment that has opacious. I helped develop an opacious B1 for children and also for brighter cases. But there are companies trying to come up with these colors now because they're very good, and we need these opacious colors in the interproximal regions and the front incisal edge length. And so after we have the sprue, light cured and sprue, then we cut the sprue off, finished with a fluted burr, remove the excess polymerized resin by scoring, and a scaler is all I use is to flip it off, and then a DET3 diamond by Brasser, retracting with an 8A instrument by Ufridi. And as you can see, we have the H274, and then the cups and the points, and you can take these cups and place them on a stone, and you'll get a thinner, and they'll go up into sulcus without any irritation to the tissue. And then, of course, I love this featherlight, and then gold-eared wheel, diamond paste, and cloth wheel, only for both ceramics and for composites. And as you can see, the completed veneer, and we have anatomical form. But this is just the beginning, because then we have the patient back, and then we cut back with an composite preparation. We acid etch to clean the surface and etch any surrounding enamel. And then we place our adhesive and also silane and then adhesive. Silane first, air dry after a minute, and then adhesive, air dry with a warm air dryer, and then light cure. And then after that, we're stabilized and we're hybridized and we're ready for rock and roll. And then we put a little bit of diluted white. This was by Color Plus, by Kerr. And then I used a little gray, diluted. I wanted to light cure individually so that I don't have any mixing of the colors, like we did when we were in first grade with our paintings with watercolors. And of course, when we have this color variation, it creates the three-dimensionality. And then after stabilization, then we overlay and we use Sculpt, which is just a hybrid, nanoparticle hybrid, and we shape it. And you could also put the guide back in, but it gets a little messy that way with that technique, so I like to brush it. And then we stabilize and light cure for 40 seconds from the facial, incisal, and the lingual aspect. And here we are with the completed restorations, noticed the nuances in the incisal third from this cutback technique. And so she wound up coming back to see me. And they wanted her to do her on the cover of the AACD journal, and her name is Ariana. Well, when she came back from Georgia, I said, well, if she has good oral hygiene, then we'll put her in the journal. But if she doesn't, we don't press this. And when she came back, she had a healthy mouth, and the patient became part of the solution through motivation and education. And you have to do this every time with your patients. And the young doctors, if you spend more time with motivation and education, you have a better patient and a more informed patient, and they'll do better with you. So I say experience, continued training, and our imagination is a source of success, and the only way we can achieve individual quality and true aesthetics. Each generation must pass on to the next generation their experience and knowledge of the materials and techniques, and emphasize the importance of continued training. Then the young professionals of the future will be able to intuitively to copy and to add to this body of knowledge, integrated into their own personalities, and perhaps draw up new aesthetic dimensions that become new standards, which we only can dream of in this moment. This is for my students, such as David in Croatia, Islam in Egypt is a very good clinician, and Rouhani that is doing very well in her studies and is a very good clinician. Next, I have one last thing to say is maintenance of aesthetic restorations is so important. The proper finishing and polishing protocol can influence the longevity and aesthetics of both direct and indirect restoration, composite restorations, and ceramic restorations by affecting wear resistance, marginal integrity, and improving the color, translucency, and the smoothness of the restoration. And my teacher, Willie Geller, said this in 1983 in Quintessence Journal. Polishing porcelain improves the translucency, the color, and the smoothness of the restoration. And for teeth and for composites, it does. Now, maintenance of the restoration, I want to talk about the fact that many times the prophylaxis that are done in the office during the maintenance therapy, they utilize coarse paste and they utilize sodium bicarbonate with air-powered devices, and these things can cause, and piezo instruments that can damage the surfaces of the composites and the tooth. And this surface roughness can contribute to the potential of plaque accumulation and retention, staining, gingival irritation, and recurrent caries. And with a smooth surface, you have none of these. So it's important that it also, this rough surface can influence the aesthetics and the surface gloss of the composite material. So it's important that you inform the patient that when they're going to have composite restorations, that they need to have intervals where you polish these restorations after the prophylaxis and charge them. But it's very important maintenance procedures, and tell them before you do the procedures so they're informed. So with this patient, he came back 5 years after we did this in New York Live, and he didn't come back. He's an engineer. We removed all the calculus deposits, the inflammatory response improved, and then we had him come back and we finished with finishing burrs. You can see the fluted ones like a DET 6 and a 274, and then also we utilized disc and interproximal strips and points and cups and diamond paste and cloth wheel. And so you can see that the completed polish after 7 years old, they're utilizing maintenance visits. And this is interesting because now the patient comes every 3 months like clockwork. Now, one last thing, and I think we have 4 minutes left. So I'd like to share real briefly the single anterior implant, immediate placement technique using injectable resin. I'm just going to go through this so you can see this. This is the maxillary anterior segment of a 28-year-old patient. You can see the incongruency of the architecture because of the deciduous lateral. So we began with a CBCT, and then of course checking, and we can see the alveolar deficiency in the horizontal aspect in the area of the maxillary left lateral deciduous lateral incisor. We probe with bone sounding, and we have about 2 millimeters of supracrustal soft tissue height. So we make our intracircular incision now, and then we remove traumatically the deciduous tooth. Of course, next we'll make our crustal buccal incision, and you can see the reflection of the tissue. And we want to make only one vertical incision, less scarring this way, and we can retract the tissue. As you see, with the osteotomy, it was repaired using a series of drills, and we follow with radiographically. The surgeon on this case was Wisam Sala, very gifted with bone grafting. The implant was placed subcrustally 3 millimeters, and then of course you can see that we did the osteotomies to perforate the bone so we can have the proper bleeding for the healing process. And of course, the cervical defect was replaced. We used a membrane first. This was BioGuide, collagen barrier membrane, and then we placed the BioOS, and then we put the screws in over that, as you can see, overlapping that, so that then we have the extra screw we place in here, the pin. So your titanium pins are placed and secured, and then we take a gingival graft and we remove the epithelial layer, and then we tuck it in between the membrane and the buccal tissue. And we secure it with a 6-aught polypropylene non-resorbable horizontal suture. And then we place our zirconia abutment prefabricated, and we had our diagnostic wax up made with our Exiclear matrix. And so we place it over the arch and we inject and light cure, and then we can see that now we cemented this transitional cement, very small amount, provisional cement. I believe we used GC Fuji Temp LT. And then you can see it 1 month post-operative view, and you still see the titanium pin that we removed later. And then we do a pickup with a transfer pickup. And so once the open tray transfer impression was taken, and we have the registration, we see remove, and we have everything we need. And then we send it to the laboratory, and they make the custom zirconia abutment. And you can see the final result. We go from an architecture that's not so aesthetic to a more natural aesthetic result. This was done by Alex Sugar, very gifted German technician. If you're using Victor and Bassam and Olivier Trick and many of the technicians that I use, they're all very gifted, and we use them for different situations, clinical situations. And so the last thing I want to say is, as I was helping my personal assistant Melissa on her master's psychology paper, I was introduced to a psychologist and philosopher. His name is Alfred Adler, who made a profound statement. And it was, every human being strives for significance, but people always make mistakes if they do not recognize that their significance lies in their contribution to the lives of others. And so the reason why I do this lecture is because anytime Marcus Blotz asks me to do something, I will, because he's a genuine individual that is really helping the students around the world and other doctors too. But I also want to say that his residents get 12 books on the flowables, which is this book. They get this book today, the residents, and GC bought those, and Quintessence helped supply those. And then they get 2 of these from one of my billionaire friends that buys books for all the students that I get him to. Every time we write a book, he buys books. So they're going to receive 2 more of these books. They have some already, but they're going to receive 2 more for the Perio Pros program. And I want to say thank you, and God is good. So now for questions and answers.
Thank you very much. Only are a Cornish white and this I'm going to really stereo. And as people know,
Dr. Black.
I think he needs to.
You have robot voice. Yes.
excuse me,
It's
You
a
have
robot.
robot voice.
was that?
Marcus Blatt's a robot.
I would recommend signing out and jumping right back in.
Mrs. Okay. Okay, is that better now?
Yes, that's much better. Marcus
Just
is back.
good. I just swapped like I just the robot is back. Now I said not only are you an excellent clinician and we always see it and terrific writer. I mean, like I said, when I work with you on some of those books, you know, the amount of information that you're able to synthesize in few sentences is just amazing. That's why anyone who has a chance, look at Douglas' book. It's just unbelievable. And also, of course, thank you for being such a great. You always have an open heart and give to the world and make sure people are doing the right thing. And also, thank you so much for your gift to our past residents, for the book, and also for, of course, your restorative book, which are all just excellent amount of information. Thank you so much. Well,
My pleasure.
but let's get to some questions, and I'm sure there's some tough ones here because I have to admit, when I first heard about a technique, I was skeptical. I'm a trained prosthodontist, so for us, blowable and restoration is like, oh, you know, it's just from a philosophic standpoint, it's something that was. I mean, when I think of John McLean, who said, you know, composite is like a puzzle because it shrinks and it stinks.
Yeah, you know, John McLean was a good friend of mine, and
I know.
and we used to talk on Friday afternoons.
I know, but I tell you something. Your book, and when we started to try the technique, several times, I'm totally bought into it. When done properly, this is amazing. Specifically, I mean, now combined also with the digital technologies, when we can do a smile design, the digitally, you know, DSD, whatever, we print a model from it, use that, and to make our matrix. I'm telling you, we have done a number of cases very successfully, and I really love the technique for the proper cases. And then when you have younger patients that may have some, as you showed, that may have still some tooth movement in their future, and then the question is, do you want to prep? Do you want to, you know, do a ceramic or whatever? And some people say, oh yes, we do veneers or crowns. And then you ask even dentists and say, okay, look at this technique. The ones who've used it, you ask them, what would you do with your children? Would you give them a prep and then a ceramic? Or would you do them this? I can tell you, most of them would say, absolutely, we go with injection. If you know how to do it properly, it's nice, you can change it, and you can always do something more invasive.
Yes.
That's the thing behind it.
But you know what? The interesting case, when you saw that peg lateral case on the young lady, I saw a patient 5 years later that came into my office, and she had spent $14,000 and she had a root canal. She had a veneer first, a composite, a crown. They worked on the other tooth. They lost the papilla. And then they sent her to me 7 dentists later. And she had spent about $14,000, $15,000. And I really didn't want to show her the video, but when I showed it to her, she started crying because we could have done that in 15 to 30 minutes, made a wax up in 30 minutes, come back in the lab and injected it. But what I want to tell the viewers, you know, diagnostic wax ups when we were in lab, we did all this, okay? And interesting is it teaches you how to prepare better and where you don't need to prepare so much. So a lot of times you can make your own diagnostic wax ups. And it's also, you know, we've talked about with children, and we utilized it on primary dentition, and it works very well.
Absolutely.
So we got questions.
I'm honestly a big fan of the technique. So somebody's asking, actually a few people are asking, why do you use a silane to bond to the composite?
Well, you know, you're probably better than me to talk about it, but that copolymerization at the interface, so we get a bonding of the materials with that. So I always, if it's, and I also etch the composite if it's over 5 minutes in the mouth. I'll roughen the surface and etch it, but it really cleans the surface. Then I silinate for copolymerization and then place my adhesive. And so that's the reason why we do it. And studies were shown by Buschleuscher and others years ago that when you micro abrade and leave those particles on there and then you silinate, then you have a better bond strength. So
That was actually
you
the
know,
next question.
you're the expert on that. Yeah, you're the expert.
Actually, no. That was a question to you, of course. And the next question was, do you use air abrasion? And you just mentioned that as well.
Yeah.
Absolutely. So, do you have any information about air abrading of tooth structure, because that has become popular as well, specifically of dentin and enamel?
Of course, I mean, I have done that too. I do that. We have it in the book in some cases, and we have discolorations and things like this. Just make sure that you isolate well before you do that.
Yeah, that's exactly
I have
true.
a question. There's a question here. It says, burr of choice to make channels in the silicone matrix.
Yes.
And the only one that I used to use an ET6 by Brasser, but now I like the 6847 by Brasser because it doesn't, for some reason, it doesn't heat up as much, so I always use that burr. Now, there's probably others too. But that's
Right.
And another question here, it says, what's the pressure in the pot to seal the stone surface? And we go to about what? 120. And that, if you don't use the pot and you just do it normally, you'll see bubbles, but for some reason they're not on the internal surface of it. But it's very important that you use the modeling gel. You place it in there. You saw me place it in there and seal the pores. I really like to seal the pores of the diagnostic model. Now, interesting is Willie Geller told me one time years ago, 25 years ago, the model is the three-dimensional effect that we have. It's everything. And so when I was in Korea one time, I was going to get a massage. So the lady came to my room to give me a massage, and I didn't know, but she gave me a massage and she walked out. So in the middle of the night, I walked out and I to go to the bathroom and I fell over my shoes. And so the next day, my friend says, do you know that the ladies that come and give you massage, they're blind? And I said, no. And she missed everything because she knew exactly, because she had that room down to a fine art. And that's exactly what the technician does with the model. They're looking at the model and they see the wear and they think, oh, there's a lot of chroma here because you can see the wear on the inside of the ledge. So that model gives us so much, but I like it so detailed. And I'm going to tell your technicians, but I might not get through to some of the dentists, but if there's a bubble on a model, when I've gone to the universities, I want to take the bubbles off. I don't want anything distorting that model. I want a very accurate model when I'm working and sealed.
Absolutely true. And by the way, just to recap, again, the silane, by the way, some people don't know, but they think always it's easy to bond composite to composite. It is, but as you mentioned as well, once it's fully cured and after a certain time, there's no free radicals, there's no surface inhibition layer anymore. It's actually not that simple to bond to cured composite. And the best way to do it is, as you said, air abrasion, and then use a silane coupling agent before you put any bonding agent. And that depends, of course, on the bonding system that you're using. Just follow the instructions. Yes. But the silane agent is important.
Another thing that we do too, and I didn't mention it, it's in the book, but we take glycerin and we'll place it over the restoration and do a post-cure of 2 minutes. And that takes the oxygen inhibition layer off and gives us a better post-cure. And like I say, I don't think anybody has given us any more information than Richard on this information. And if you haven't read it, if you read either one of the books, you'll know, and also in our new book that's coming out, you'll know more about it than anyone. And he's so excited. Now, one more thing I forgot to tell you. There's a post in Core that's just come out, and I'm going to give you something, a sneak preview, but it's called a Lumi post. And Dr. Burgess has done some studies on it, and the curing goes all the way to the tip, so we're able to use just a light cured resin. We don't have to use a dual cured anymore with that system only. But on the studies that Richard done recently for us, you don't have a light cure, so you really have to use a dual cure on most of these other posts. And people think that these light cured posts are magic, but they're not. And so they might have an incomplete bond at the apical third. So I think the Lumi post is where we're going. So you might want to look it up. Interesting.
How about the shrinkage of flowables? Is somebody asking, which modulus of elasticity should we choose for flowables to absorb the shrinkage stress of the composite and to feel that it's filled?
Well, that's a real good question. But also there's another thing. When you place the post, for example, okay, when you're doing a post, If you place that post and you leave it and delay your cure, you get a better bond than if you light cure immediately. So it's very important that you delay your cure. Delay a minute or a minute and a half. You think you're in a hurry, but you're not. You don't have to be.
And okay, and for the flowable shrinkage, is that what you recommend to do to prevent that? Or if somebody was asking this, what about a higher shrinkage? Are you concerned about that? Is it still a fact with the newer materials that you're using?
They're similar to their counterparts, and so I don't really have a problem with it.
Yeah,
in fact,
there's a.
If you look at them, when you see the interfaces, if you have a good diagnostic wax up, and that's a question that we need to talk about, is a lot of times when you go to the American labs, for example, they'll make one master model for everybody, and then they put it on their articulator, and then when you inject it, there's no occlusion, and then you have to grind everything out. But when I transfer, if I have a transferable diagnostic wax up, and I make my matrix, I don't have to equilibrate when I'm finished. There's no adjustments at all.
Yeah, I agree.
It has to be translatable. So that's why I want the residents to know that the diagnostic wax up, when you make it, a lot of these companies, they'll make them, laboratories make them, and they come in, and I don't use them, but they want to do it as a selling feature to sell the case. But they're not thinking about the significance of that person. And when I wrote the article 25 years ago, Stone Models Without Faces with Willie Geller and others, I think Matt Roberts was one of the persons, and Charles Marino, but we were talking about the master model being so significant in the diagnostic wax up and giving us everything that we need.
Can you use this technique with the rubber dam? I think you showed.
Yeah, you can. Yeah, I've done it with an Owen modified technique, but see, my personal opinion is the silicone acts as the dam because it separates everything. So I think that we're okay that way. Now, when I had the column in PPAD and I wrote the piece about Liebenberg was so significant in writing about the open dam technique with a little bit of cyanoacrylate so you could have some room there. And so that's another good way if you want to do that. But I had no issues with it, using it just with the silicone.
How about posterior teeth? Do you use that with the flowables as well? Is that something that you do?
Yes. In fact, you'll see some in the book, and also for making provisionals. And what's interesting is if you're making single unit provisionals, or I like the Exiclear because you can see it, and if you want to inject it or just want to place it, you can take your Luxatemp or others, and you can see if there's a void, and you can move the material, and you don't get voids. So I use Exiclear for making provisionals also, but also injecting technique.
Right.
And somebody
and how do you mix the injectables? Somebody's asking, how do you mix the injectables?
Okay. Interesting is that you get your color of your dentin, and then you'll know that you want to block light or you don't want to block light, and then you'll want to transfer a color over, a translucent color. Now, when we were doing, it was Dieter Dietschi, myself, and Newton Fall, and Vanini. And the four of us were hand bonders, in the world. And so when I would go and give a hand-on course, one person out of the group might do it really well or get it. But the other 30, I had to help. But when I gave this injection technique all over the world, to even up to 50 people, light bulbs came on and they all walked out of there and they could do it. Now, interesting is, when I said predictable, it's very predictable with multiple restorations. And like I told you, when you're doing post and course, Bert just told me the other day, wow, this would be really good if you had multiple restorations that you need post and course. And it would, because you already have everything predictable, and then you just inject and then you're done. You don't have to adjust. So
that's the point.
The book gives a lot of avenues. I give you 5 videos. I spent about probably $50,000 on making the videos, but I wanted them to be free with the book. So they're QR readers, so they can watch them. And I tell them, go to the table of contents and watch the videos. And in the big book, we have 30 videos in the big book. But I want them to watch the videos because then they see things that maybe even in a lecture you don't see, you know? And it takes a lot of time to make these videos, but it's significant.
Also, at the quality, of course, you're doing that. It's just amazing, you know. That
God is good.
The way you do it.
God is good.
No, it's fantastic. Somebody's asking when you have just an incisor fracture.
Wait a minute. One more thing. Because my personal assistant thing. When we mix colors, though, okay? So, for example, we have a cuspid and we're going to do 10 veneers. So we know on the cuspid we want a little bit more chroma. So we'll take like an A2 or an A3. Now, I don't like A3 so much, but in America they don't like it. But you have to convince them. But interesting is you want this. Now, if you want a little more brightness in the center, for like Willie always says, hey, give them a little punch and give them a little brightness in the center. So you'll use like a little B1, okay, translucent in the center. And you learn to mix them, and then you learn how much you squeeze and how much you do. And in several months' time, you'll be so good at it. Now, let me tell you what's going on around the world right now. Kids all over the world, I say kids, 35-year-olds are doing this. All residents, prosthodontists, periodontists are doing it. They're telling me, man, I'm just going to do a connective tissue graft, and I did the provisionals first, and I bonded them, like you said, and then I can do my connective tissue graft, and nothing moves. It's beautiful, you know? So there's so many avenues that we can do, and that's why I want them to know that it's just a supplement to complement where we're going. And when we started this technique, I started on very wealthy people, and I was doing injectable, but I called it prototyping. Okay, prototype. Yes. But then I saw my prototype weight is 13 years, and he comes in. He was in here about a month ago, and he says, "Do you still have that matrix?" And I said, "Yeah, but I also have the diagnostic wax stuff." Well, if one of these ever chips, can you just redo it? And I said, "Of course." And so he's a very wealthy man. Okay, another person that's in third in charge of United Airlines. I did all his teeth, and he had ceramics. I took them all off. It was done by an accredited doctor, and it looked like terrible. So we got him his form and shape, and we injected him. And he said, "Well, when are we going to put the ceramics?" And I said, "I'm not sure." So now he tells me, "Douglas, I come all the way from Newport to see you for cleanings because you know why? I trust you." He says, "Everybody else would have wanted $40,000. Well, you know what? I want to know where we're going with this product. Now, I see some young doctors, and you know some, and they want to change the name to a new name. Well, we don't have my name on this. It was basically other people were doing it. Musella did it years back too, but the flowables weren't very good, and so it didn't work so well. But interesting is they want to do one case and say, "Oh, let's change it to my name and all this." But this is not where we are. I want to give you information that when you go home, you and I both know that there are technicians and clinicians that say, "Oh, it's so easy," but when we go home and we try their technique, it doesn't work. Well, let me tell you something. When they try this technique, light bulbs go off because they're so excited. They're thinking about the next project they're going to use.
I agree.
I had a guy from Italy. He wrote me a letter and asked me to come on his boat. And he said, I saw him in Scandinavia country, and we're doing a hands-on. And he wrote me, "Well, you know the best thing I learned?" And I said, "What's that?" "The Bard Parker." He says, "The course was expensive, but that Bard Parker was the best thing I ever learned." And you know what? If you think about it, the Bard Parker in adhesive dentistry is the most utilized instrument, or should be. You know, just little things.
Absolutely right.
And there was three prosthodontists in South America, in Peru, and they were watching me this, and I had 1,200 people there, standing ovation. But it's interesting. These three prosthodontists, before I got home 2 days later, they already sent me a case.
There you go.
It's revolutionary. So you use it how you want it. You may want to go to ceramics, or you know what's kind of interesting? Full mouth cases sometimes can be very expensive. And in our office, it's up to $250,000 for a full mouth case. Interesting is, a patient may not even be able to afford a tenth of that. But if you take them into an injectable full mouth and get the occlusion right, then you can do the anterior guidance first in the anterior region, and you can do it in quadrants, and then you can go back another year and do a quadrant and a quadrant. And so you're not getting wear, but you can change them out to ceramics.
Absolutely. And you don't even, there's so many people actually have, of course, followed in your footsteps and now preaching the same thing, because we have learned that it's really a great technique. And of course, it's case selection as everything. But when you think about it and when you start using it, you understand it becomes broader and broader and broader. Like I said, we have done a number of cases using it either as a prototype from, for example, from our CAD/CAM design to make sure we're on the right track, and we can always exchange it with something more invasive, but you can never go back. That's
well, you know what else you can do? You know what else you can do? It's kind of interesting. We did one several times. Is that I don't like the wax up. I don't like the form. And so Bruguera did one, and I said, I don't like this. I'm going to let Olivia Trick do a wax up. So what I do is I can just cut the surface back, make my modifications, and then I can acid etch it, silinate it, adhesive, and then I can re-inject, and I can change the form to the original one. So I can resurface that one like we did in that you see there. So I can resurface and change the form until I get where I want, then take my infusion and make my ceramics.
Exactly. And by the way, even if I have to do it, but what is your preferred, again, your preferred resin flowable material? What's your preferred?
You know, Clearfield Majesty is very good. Voco has one that's very nice, but they need to listen a little bit because I think that really it's a little, it doesn't polish well. But as far as strength, it's very good. And then, of course, Genia Universal Flow is the one I helped develop, and I helped make the Exiclear, and they made the colors that I wanted. Now, interesting is some of the other companies are calling, but I need them to all give us the AO and the BO one. We need opacious colors, and for pediatrics, because it's great for pediatrics, because you know when you asked me to talk to Penn years ago, and we talked about this concept of interior composite crowns and all the different possibilities for crowns for children, and none of them look good. But when we went to India and we did those kids and they stood in line and we did those techniques, they all look beautiful. So I mean, there's a lot of applications.
Absolutely. Oh, somebody asking a question a little bit off the topic, but of course relates to that as well. What occlusal scheme do you prefer? Canine guidance, group guidance? What is your idea when you do this?
I think it depends on the patient and where we're going and what we have. I mean, I can't just say one for all. No.
Exactly.
So, but I want to protect it, and I know that, you know, probably a better question. I mean, when we talk about parafunctional habits, okay, we just need to have exactly. They need to be balanced. If they're not balanced, then nothing's going to work. So we just have to have balance.
And when you just have an incisal edge fracture, for example, do you just replace the missing part, or does it always have to be entire surface, or how do you do that?
That's a real good question. Depends on how old it would be. But I've not, knock on wood, because I maintain my patients closely, and I check equilibration. Now let's go further with that just for a moment. When we do post and cores, okay. When we do that, in Meinberg and others will tell you, interesting is you really need to watch the occlusal scheme, but you need to watch the occlusal scheme on your patients when you're doing maintenance visits, and it just takes a few minutes in a prone position and an upright position, because there may be a prematurity that they developed, and you can improve the wear by just watching and polishing. But if you're going to equilibrate, because one of my surgeons may be listening, interesting is when he equilibrates, he forgets to polish, and so that makes more issue. So you really need to polish well, and you can see that in our 3rd edition, and we talk all about how important it is to polish and what you should do. So that's real important.
When you have some patients, and that's of course one of the patients you would think about that have gastric reflux or acid erosion, is this something that you would do there as well, or is the longevity compromised? Do you have any information on that?
Well, it depends on where they are. You know, we have patients that we've seen where they have lingual erosion.
Exactly.
You know, and so we've replaced that. But if they haven't changed that, then of course it's gonna have a rough interface, and you're gonna have to keep maintaining it well. I think you know, they say my work sometimes really says it's art, but I think the reason it maintains its art ability is because I make the patients come accordingly. For example, you can see a patient that's been coming to you every 6 months, and they've had periodontal surgery 3 times in 5 years. And then I see a patient, I say, you're retired, why don't you come once a month, and we'll just do it every month. And then they quit having problems because you maintain that patient better. Now, if you, at the same time, if you have restorations, you know, when I see the crown or multiple crowns, I don't let that be it. I have them come back in 24 or 30, or 48 hours. I let them come back and I check their equilibration, because how many times have we seen in the ground and we thought it was right, and then we see later, after anesthesia is gone, that they may be off a little bit in their occlusion. So all these things, maintenance is the word, and that's the next you and I need to write, okay? On maintenance.
No, absolutely true. No, maintenance is absolutely key, for any restorative and of course specifically also periodontal treatment. And to the idea, and that's why I'm so happy about your techniques, is to be less invasive. And the same is, and to keep teeth as long as possible. And when you now talk to many of the top implant people, that have done implants not for 2 or 5 years, but for 15 and 20 years, they now tell you, all of them, they should have been less aggressive, more careful, should have not placed as many implants, and sometimes tried to keep the natural tooth longer. That has to be one of our absolutely primary roles that we have to do as dentists. Of course, we can always do implants. Of course, we can always do crowns, but it's where you start with it. And that is from when we talk about teeth. Diagnostic.
Otto Zur, I've had dinner with many times, Otto Zur and Hirschlinger and others. They indicate, and they've done so many implants, and said, you know what, that's the end stage result. So we want to do that at the end. In the anterior zone, if there's any other possibility below the age of 30, and I've been to seminars here in Houston where they're doing it on 18-year-olds, and I'm raising my hand and they get mad at me, but I say, this is not acceptable in our society now to do a 17-year-old implant in the anterior zone. It's just not. So.
Oh no, absolutely. And the age recommendation goes up and up.
Yes.
I think we're up as well when you talk about time. And again, I'm interested. Your books are fantastic, and I have no problem making a little bit of promotion here, because we know that as authors,
buy a book for a student.
Exactly.
One last thing,
information.
Let me tell you one last thing. Buy a book for a student. There was a gentleman who just passed away. His name was Rudy Fulton, and he was a professor of ours, okay? He comes to my office for coffee. I did all his teeth. But he come for a day, and I said, you need to buy a book for a student. He bought the book for a student with his credit card, and then about 3 weeks later, he gets a call from this lady doctor at the University of Florida, and she says, Dr. Fulton, you were my professor in school at University of Texas, and you know what? You bought a book for my student. He called me, and he was so excited because he said, now that's a really good idea. Buy a book for a student. So if they want to buy a book for some students. All right? And we're all students.
Up for a lifetime. Absolutely. Thank you so much again. Thank you, Douglas, for coming on board here and then coming back to Penn Dental Medicine. It's been always a great pleasure. You're a true inspiration and big heart, and we really love your work and also love what you do as a person. Thank you so much for that. Everyone listening, thank you also for being here and listening to us. We have, of course, a continuation.
We know it's like 2 o'clock in the morning in India. And so my students are saying it's 2 o'clock and they're up watching. So this is real dedication. Thank you.
Well, it's because they know that it's worth it to stay up this late to listen to you. So what are we also going to have in the next week? We have Alessandro Pozzi talking about implants. The following week on the 29th, we have Iñaki Gamborena talking about the book. We have put the book Evolution together.